Hello, and welcome to our talk about modeling and minimizing the impacts of infection control routines on nurse workload in acute care under varying COVID-19 outbreak scenarios. My name is Patrick Newman. I'm a professor at Ryerson in the Industrial Engineering Group. And this talk is co-hosted by Sadim Qureshi, who will be joining us in the question and answer booth, I hope, tomorrow. And I wanted to tell you a little bit about this formative project, which is part of the Better Work, Better Care Coalition, aimed at improving both working environments for care providers, such as nurses, and the care that's then delivered ultimately to patients. And that's a lot of what this project is about. We are a multidisciplinary team. We're working with the University Health Network, specifically Helen Kelly at TGH and Unit Manager Anne Van Dersen at Toronto Western Hospital. We're a mixed team from the Human Factors Engineering Lab, myself, Sadim, and Dr. Michael Gregg. And we're joined by Dr. Nancy Purty and Dr. Sue Bookie-Bassett of the Nursing School at Ryerson. And this is a productive and really interesting collaboration between our disciplines. As background for the COVID project, we have vast numbers of healthcare professionals that have been infected and hundreds who've died as a result of the COVID-19 outbreak. This poses a double hit to the healthcare system because on the one side, we lose the caregiving capacity of those staff, and on the other, they increase the workload because they themselves then need care. And this is an environment when nurses are already overworked. We have large concerns about injury rates in nurses, accidents, musculoskeletal disorders, and over 20 million hours of overtime each year worked by nurses in Canada. Additionally, there's concerns around the infection prevention and control routines, IPAC, as it's referred to, and that these may further increase workload, as well as the workload of the patients themselves, which makes the overwork situation and the fatigue and the possibilities for accidents, injuries that much greater. And our interest in this is trying to provide decision support tools and modeling tools that could help understand these consequences. And so what we're going to present is our approach that we've been developing for a few years now, in which we look at the design of the healthcare system closely. Where are the beds located? What's the architectural layout? What are the tasks being used? What technologies, how and when, and what are the demands for patient care? And all of these system design parameters then will determine the healthcare professional's workload. In this case, we're dealing mostly with nurses, but the technique could apply to other healthcare professionals as well. And from that workload, we're concerned about the development of fatigue, and we're concerned then also with the subsequent care quality, patient safety, and the occupational health and safety of the staff themselves. So the modeling aims to tie these elements together, and I'll try to explain just how we do that over the next few slides, as we use these computerized simulation tools to really model the delivery of care and the workload associated with each delivery, each task delivered on a task-by-task basis over a full shift. And we're working specifically with a medical surgical unit at Toronto Western, but also with the emergency departments at UHN, where we'll be moving to next as this project gets ramped up. In sub-project B, we're actually trying to improve the IPAC routines in order to make them more reliable, easier, faster, and less prone to error. So a workload minimization effort, and we're doing that with a conventional quality improvement approach, but targeted in this case to the workload associated with IPAC routines. The system we're using, discrete event simulation, is a conventional industrial engineering approach that takes complex systems, breaks them down into a series of discrete points, perhaps with variable times, variable occurrences, and some quite complex sequences according to whatever the process you're trying to model is. And it's been well used in manufacturing and aerospace, service industries like banking, and quite broadly in healthcare as well. The difference here is that we're really looking at the delivery of care from the perspective of the caregiver. Most of these simulations are looking at the product moving through the factory, or the patient moving through the system, or the customer moving through the store or the bank. And so we're turning that around a little bit to really make it worker-centered and understand what the demands on the worker are. So here's an illustration of how the model works. We have our patient care data, the tasks, the task times. We have our actual unit layout, the architectural drawings where we go to measure them, the logic obtained from the nurses around how they do their tasks, what movement patterns do they use, what sequences do they use. We obtain this talking in focus groups directly with nurses. And then we've also gathered data on the physical workload. And all of these go into the discrete event simulation that integrates all of this evidence, both in the time and the geographic domain, to start giving us information about nurse workload and quality of care. Nurse workload indicators could include peak and cumulative compression on spines and shoulders, moments of force. The number of tasks in a queue is an indicator of mental workload, how much you have to have in mind, how many tasks are on your mind that have to be delivered. The cumulative distance walked is another important indicator. The amount of time in direct care, and the fatigue level. And this is the new piece that we're trying to get in here, both within shift and between shift fatigue accumulations that we're concerned are associated with error and accident. Quality of care indicators can include missed care. These are tasks left undone at the end of a 12-hour simulation run or simulated 12-hour run. The missed care delivery time, the total time that all of those missed care tasks would add up to, and the task and queue time, the amount of time a task waits before the nurse, according to her working logic, can perform that task. Just to give you an illustration then, here we have a little animation from the simulation. Our layout here is really just a sketch. We have high precision drawings actually when we determine these distances. Here the nurse went to the medication room, the linen cart, the clean room to get bedding, and then into the single bed to provide the care, and back out, dropping things in the dirty room for cleaning, and back to the nurse's station. And this is sort of an example then to let you see the kind of logic that the model is enacting, and that we apply the distributions observed at the site for all of these various tasks. So a natural question is the validity of the process. So I wanted to show you this. Here we're looking at the distance walked for each of 10 nurses that we studied. And we followed these nurses in person using a Fitbit to look at exactly what they did walk. So we measured walking distance, and we used two different care task logics. So when we conducted our focus groups, we found there were slightly different logics between how the nurses did their tasks. Rather than forcing it into one single logic, we said, well, we'll just test both. And that's essentially what we've done here. And so the gray and zebra striped bars are the modeled outputs, and they are slightly overestimating, but tracking very well the measured outputs. So our intra-class correlation here at 0.97 is extraordinarily high. And we see, for example, nurse 4 is walking roughly 11 kilometers in a shift based on the tasks and the assignments they had for that day. Whereas nurse 5, on the day we studied them, had walking distances under 8 kilometers, maybe closer to 7 kilometers. And so this gave us some confidence that the configurations we're putting into the model are actually representing the type of walk distance and the type of patterns, movement patterns that we see in real life. We also followed the nurses around, seeing which rooms they went into, and that also matched what we saw with the model. So we have some good confidence in the way this kind of modeling is reproducing what nurse's task and task sequence are. So here's an example. I have a couple examples of model output then. Here we have 5 different patient ratios. So a nurse with 2 patients, 3 patients, up to 6 patients. And we simulate that for a number of different acuity levels, where blue is the baseline. This is what the current situation was over the last year when we went into that med-surg unit. And then we bumped up the frequency and the duration of critical tasks according to anticipated increased patient frequency. So you can imagine if you suddenly have a patient that's much sicker, then there's going to be more care delivered, and that's going to be a greater workload. Our output here is missed care. So these are the number of tasks left undone at the end of a 12-hour shift. There may be different ways those tasks are accommodated. So the next shift, the next nurse may pick it up, the nurse may work overtime. But the fact is, the plan was to have all this work done in 12 hours, and it simply wasn't possible. And here's the amount of leftover work. And so modeling like this lets us understand just exactly what happens to the workload under these complex systems, to the workload of nurses according to the configuration of the system. With care delivery time, we start to see ceiling effects. So this is the amount of care delivered in a day. And this, essentially the ceiling effect means that beyond that point, it's simply not possible to deliver more hours of care in a 12-hour shift. And so we can see over here on the left with 2 beds, the nurse is underutilized and really is only delivering care up to, say, 10 hours per day. But in 3, 4, and 5 beds, you very quickly come to the point of saturation where the nurse simply cannot deliver the amount of care that's required for those 4, 5, and 6 beds according to the acuity of the patient. We then wanted to start to look at some of the physical workload aspects. And so to do that, we made video recordings of each and every task. And for each task, then we conducted a biomechanical model. And that gave us some indicators of spinal load and shoulder loads that we could associate with each task within the model. So when we start to connect the tasks being done in the modeling universe with the biomechanical loads, we can start to create a trace of workload, something like this, where we see what the cumulative load is according to the biomechanical demands and duration of each task, and start to add that up over the course of an entire shift. And while there were some cumulative loads, some peak loads were quite high, and those tasks might warrant a closer look as to how to perform them in a better way. Washing patients' head, for example, is particularly difficult physical task because of the postures associated with it. But in this, we're also concerned with the cumulative load, the total load that adds up over time. And when we start to look at this, we have, in this case, we're looking at yet another design feature, the distance of the beds from the nurse. And here, 26 meters, that implies that most of the beds are quite close to the nursing station, whereas way over here, whoever has this assignment, 47 meters, has beds all over the unit and has to travel to get there. The output indicator in this case is the variation from baseline for both the cumulative distance walked, so that's our distance indicator we looked at earlier, and now the cumulative spinal load. And what's interesting here is we see, and expect we hadn't considered at first, but as the nurse has to move further, has bed assignments further away, they spend more time walking, more distance walking, and therefore they have less time to deliver care. And the care tasks are what's providing the cumulative spine load. And this therefore means that spine load is going to go down as the walking time goes up. And we weren't anticipating this, but it's an important issue that illustrates how the model can help integrate a wide variety of indicators and system design parameters to estimate what the workload is for that particular nurse. Okay, so we're applying that then in situations of COVID-19 with various infection rates and starting to gather that data now. We're also getting ready to engage in a process improvement work, trying to engage in multiple plan, do, study, act cycles at the hospital. That's their standard care improvement approach. So we're piggybacking on existing knowledge on how to improve processes, but bringing the focus on healthcare workers in the infection prevention and control routines. We're engaging also in the infection control director, unit managers, and other stakeholders in this. So this is closer to a participatory ergonomics approach that we'll be applying. Of course, our changes will be evaluated both with subjective and objective evaluations, but we also want to check it with a model and see what that tells us about possible other side effects of changes in the way the infection prevention and control routines and the logic that's brought to work in caring for COVID patients affects system outcomes. In terms of potential impact, the computer simulation models are really a decision support tool. And I think this is the road of the future. So it's a new approach to measuring and quantifying workload. We can isolate the impact of changes or proposed changes to nurse workload, nurse fatigue, and quality of care outcomes. So it's incredibly powerful. And once you have a model built, it's very easy to reconfigure it for different situations. But it really is a way to move past the argument that the classic labor management argument, where labor says, we're working too hard, and management says, no, it's fine. Really what you need to do is use a tool to understand what the actual implications are and act on that. Further impacts the process improvement. Well, we hope to have improved IPAC routines with reduced workload. We will hope that that also leads to reduced infections, both amongst patient and nurses. And we'll have proactively tested these approaches using simulation to understand what their larger impacts might be on the care delivery process. These kinds of projects will also, we hope, strengthen the quality improvement capability at UHN and our partners, which is always a good reason for engaging in these kinds of processes. It's not just the outcome of this single project, but also the increase in capability of the people that have been involved in that project that are the benefits from engaging in these kinds of efforts. Okay, so possible future applications. There's all kinds of issues that remain to be examined, and these could include evaluating things like nurse-patient ratios. It could be COVID versus non-COVID patient ratios, the forms of IPAC routines and IPAC strategies, performance of novice versus expert nurses, changes in architectural design and layout, changes in technology or hospital beds, or other tasks that emerge as new care routines and policies are considered. So the modeling ability is still formative, but I think is growing quickly, and we're going to be able to look at an amazing array of issues using these kinds of simulation techniques and understand what that means for risk to patients and what it might mean for risk to staff. We're looking at moving into continuous complex care and long-term care scenarios. We may work also with other professional caregivers, including personal support workers, depending on the needs of these particular settings. So we're not confined to just medical surgical units, and we're not confined to only working with nurses, but this was our start point, was our home base. And with the large number of nurses in the healthcare system, that seemed like a good place to start. And we're always trying to look at multiple safety and quality outcomes for both nurses and patients. And that's what I think is interesting about these kinds of simulation tools, is that you cover all bases if you have a well-designed model and can really see the balance between and potential trade-offs of accepting perhaps less efficiency in the short term for longer safety and quality in the long term. So in conclusion, this project is developing a new method for quantifying workload that can account for a lot of design features. These computer simulations that let you do proactive assessments, you can do what-if tests, you can look for ceiling effects in certain variables and help managers make better decisions around what their operational policies are or around what technical design issues might be. Subproject A, the modeling work is currently underway, so we're embedding COVID-19 realities in terms of work process, work routines into the modeling work, and we've just had clearance from the research ethics boards to initiate the process improvement work, and that's what we're hoping to do now. So I want to thank you for your attention, and I want to thank the PSHSA for inviting me to talk. Do please follow us on the Better Work, Better Care tag on Twitter that we're starting to use to share information on this. We thank CHR, of course, for the funding and look forward to presenting more complete results as this project moves forwards over the next year. We look forward to handling any questions in our booth and hope you enjoy the conference. Take care and bye for now. Okay, thank you for that.
Thank you so much, Dr. Newman, for sharing this research, which supports a more proactive approach to planning and improvements to the working environment for nurses in acute care. We can open up the questions for Patrick. So if there's any questions in the chat, I can bring those forward to you, Patrick. There is a question or comment here.
On staff shortages.
Yeah, is there something that you are considering with your research as it will affect workload?
Yeah, we're certainly looking at both the level of staffing that's provided. So the examples we had of nurse-patient ratio, for example, is one way that we look at that. I think the other concern with COVID patients is the acuity and the amount of workload that might be much higher for those patients than for a patient that particular unit might normally see. And both of those are elements that can and will be tested with this kind of modeling. And yes, long-term care, we have our eye on long-term care. We are currently building a coalition in that area and hoping to get funding to work with long-term care in the future. So that's definitely a way forwards. In the early stages of this kind of modeling, we needed a more regular type of work that the med-surg unit was providing for us. But we're at the stage now of trying to broaden out, and long-term care would be super interesting if we could get a project going there.
Thank you.
Yeah, no problem, Catherine. Other questions from the audience in the chat box or verbally? Or maybe you can't verbally, so chat box then.
Yeah, it is the chat box for sure. Patrick, if you had to say, what is a hidden kind of blessing or benefit from this current situation with regards to the research you're doing?
Well, I think it's brought a lot of attention to, I'll call it the plight of healthcare workers. And we see lots of people that are grateful for the healthcare system and the healthcare workers' efforts. And I think it's brought a lot of attention to the issue. And I'm sort of hoping that translates to political will to fund our healthcare system appropriately. And that would certainly be a blessing. And we hope that in the course of that debate, that the tools that we're able to produce can help resolve those questions in a more quantitative and evidence-based way. So I think that's sort of one of the hidden benefits we've seen for many, many years, pressure increasing on the front line where all the time we're trying to make savings in our healthcare system, and it ends up affecting the workload of the front line. And I think this situation has really highlighted that situation, and I hope that we're able to leverage that for an improved and more rational approach to healthcare service provision in the future.
Thank you. And are there any other projects that you're leading that are related to COVID that you want to mention or speak of?
We're not a flat out COVID house here. So this was a situation that came up in the course of our modeling work that we are using as a context in which to develop the kinds of decision-making tools that we specialize in the Human Factors Engineering Lab. So our work broadly really focuses on the ability to understand, predict, and manage workload and health hazards over the longer run in these systems. And so I'll say, no, we're not targeting specific COVID issues, but what COVID does is intensify some of the problems that are happening and have been happening elsewhere. So the trend of working at home is a long-term trend, right? But now we have a huge spike of work at home. So some of our work right now we're starting to look at monitoring of employees and performance monitoring, and what the implications are of that for the employees' well-being, for stress, but also for serving the needs of the organization to understand, when people are having problems and might need support. And so these kinds of efforts to look at how we manage our work systems, how we design our work systems, are just made that much more acute by the COVID situation. But with or without COVID, I don't think those pressures are necessarily disappearing entirely, as companies always look for ways to rationalize their processes. And so that's where we're trying to step in by providing models, decision-making tools, even simple tools like checklists that can help people understand where their workplace is running into problems. Problem from Catherine here. It would be good to look, she says, at hand hygiene and how much does it affect time workload, given its importance. Yes, I think the infection prevention and control efforts, process improvement effort will definitely include hand hygiene issues, as well as donning and doffing of PPE. All of those things are critical both to prevent infection control, but also that they add workload, and they're one more thing you have to remember, and they're one more, there's sort of one more task that you have to make sure is done in the right sequence. And that increases mental workload, can contribute to stress, above and beyond simply the ongoing concerns and the mental pressures of worrying about infection. And I think all of these will be part of the comprehensive look that we do in the process improvement work. So indeed, that's one piece of the puzzle, I think. Thank you, Catherine.
Thank you. Are there any more questions for Dr. Newman? We've had a great questions. People are saying thank you. So I would like to thank you, Dr. Newman, for sharing your information and your research to help us all reimagine the workplace during this pandemic.
Thank you kindly, and people are more than welcome to contact me at Ryerson by email, and we can chat. I'll be around a little bit longer if people want to chat online. That's fine too. Thanks everybody for your attention.
Yeah,